pharmacology terms, discuss how drugs are sourced, how they're developed, advantages of drugs given by inhalation, and related drugs used in respiratory care. First, let's discuss some general terms. Pharmacology is the study of drugs, including their origins, properties, and interactions with living organisms. Pharmacognosy is the identification of sources of drugs, for example, thyroid medicine developed from dissected pig thyroids or digitalis from the foxglove plant. Pharmacogenetics is the study of interrelationship of genetic differences in drug effects. Therapeutics is the art of treating disease with drugs. And lastly, toxicology is the study of toxic substances and their pharmacologic actions, including antidotes and poison control. Next, let's discuss how drugs are named. A chemical name is a name indicating the chemical structure of a drug. For instance, water's chemical name is oxidane. Of course, we know the chemical formula is H2O. A code name is a name assigned by the manufacturer to an experimental chemical that shows promise as a drug. An example is the code name for albuterol sulfate. You know it as Ventolin or Preventil, is RO3AC02. Generic names are assigned by the United States Adopted Name Council, or USAN, when the chemical appears to have therapeutic use and a manufacturer wants to market the drug. For instance, the generic name for Atrovent is ipratropium bromide. Lastly, we have the trade or brand name, which is the name given to the drug by the manufacturer and is considered a proprietary name. You will recognize a trade or brand name by the little r above the name, meaning that it is a registered trademark name. Let's look at some sources of drugs. We briefly mentioned the term pharmacognosy and mentioned an example of an animal source for thyroid medications and a plant source for the cardiac medication digitalis, but minerals can also be used as a drug source. If you've ever soaked a sore body in an Epsom salt bath, you know that mineral, magnesium sulfate, can ease the pain and swelling of sore muscles. But did you know it is also used to treat torsade de pointes, an arrhythmia that often leads to sudden cardiac death? Most drugs today, however, are chemically created in a lab and are put through a lengthy, expensive process for drug approval. Once a chemical is isolated and identified as having some therapeutic effect, generally animal studies are conducted to see the effects on organs, its tetragenicity, which is the effect on reproductive fertility, and carcinogenicity, or its potential to cause cancer. Then it is given investigational new drug approval and must complete the next 3 phases of drug approval. Phase 1 consists of giving the investigational drug to a group of healthy volunteers. Phase 2, where a small number of individuals with the disease this drug is intended to treat are given the drug. And Phase 3, where the drug is introduced to large multi-center studies to study its safety and efficacy in large populations. This approval process can take up to 15 years and $1 billion to bring a drug to market after Federal Drug Administration or FDA approval. Some drugs, named orphan drugs, which are used to treat rare diseases with less than 200,000 persons affected by the disease, will not recover their cost, but there are several of clinical importance to respiratory therapists. The medication Dornase alpha or pomazine in the treatment of hypersecretions and viscosity in cystic fibrosis patients is one example. But whether to pursue the development of these drugs is an ethical dilemma in drug development. As respiratory therapists, we already know that aerosolized agents have many advantages over those given parenterally, an example IV or orally. Those advantages include smaller doses, fewer side effects, rapid onset. Usually before the treatment is completed, the patient will find it easier to breathe. Targeting of the respiratory system, and of course, respiratory treatments are relatively painless and safe, with the most common side effects being tremors or increased heart rate. The groups of respiratory agents that we will be discussing in future lectures are adrenergic agents such as albuterol or Ventolin, anticholinergic agents, including ipratropium bromide or Atrovent, mucoactive agents like acetylcysteine or Mucomyst, corticosteroids such as fluticasone or Flovent, and nonsteroidal antiasthma agents including montelukast or Singulair. There are other related drug groups in respiratory care, most of which we'll cover in subsequent lectures. They include anti-infective agents such as tobramycin for Pseudomonas infections and cystic fibrosis or bronchiectasis, neuromuscular blocking agents, which are commonly used in rapid sequence intubations such as succinylcholine, central nervous system agents that we often see in the ICU for sedation such as propofol, antiarrhythmics often used in both the ER and ICU, antihypertensives and anti-anginals used to treat hypertension and angina, anticoagulants and thrombolytics for pulmonary emboli prevention, and lastly, diuretics often used in congestive heart failure patients.